You're here physically, maybe not mentally. Okay, so I just want to go through a couple topics that I think are really important to talk about as far as just like medication safety goes, just as sort of a summary. No doing drugs, no real testable content, with the exception of I will ask a short answer question on this exam, which always makes people nervous, but it's worth 5 points, and if you put something like thoughtful down, you'll get full credit for it. And basically, I'll go through some stuff about medication or transitions of care through different aspects of the healthcare system and why it's important to watch out for them and what kind of pitfalls there are. And so it'll be just a transition of care related question, something to the nature of, in your future practice, how would you prevent medication errors during transitions of care, something like that. And then you can write a small paragraph, and that's all you need. I'm not sure exactly how that works on the e-value. I'll have to double check and make sure it's set up that way, but that should be not e-value. What did I call it? What's your test system? Too many acronyms. Okay, e-value is the U of M one. Okay, e-medley. Gotcha. Okay, here we go. Okay, so medication safety. I want to talk about medication safety. It kind of seems like a boring topic. It's actually really important, and I think it's kind of exciting because lots of stuff happens with medication safety. That's really, from my perspective, ultimately, if you boil down what my profession is, a lot of it has to do with this. So if you're ever looking for resources on certain things, and again, these are things I get questions on from providers all the time. First of all, can you crush a medication? Well, there's something called ISMP, which is the Institute for Safe Medication Practices. They have something called a do not crush list. A lot of hospitals have protocols and policies around this kind of stuff too, but let's say you're prescribing outpatient and you don't necessarily have access to a comprehensive protocol or policy. You might be able to go to this website, or you should be able to go to this website, I should say, and they have a do not crush list. Generally speaking, anything extended release you can't crush, but some things are a little bit odd, like for example, metoprolol extended release actually is scored, so you can split that tablet in half, even though it doesn't make sense. Usually with something extended release, when you crush it, you destroy the mechanism that releases it and sustains its release. But some things are designed to be split in half. So just so you know, there's some exceptions to that. Doesn't mean you can crush it. That would still ruin it, but you can split some extended release. So that's kind of a general rule. But there's a lot of things that don't really make sense. There's a lot of capsules you aren't supposed to open. So some people just say, oh, just open the capsule and put it in applesauce or whatever. No, it doesn't work for everything. A lot of things it's fine for. But just so you can go to that website, and that's a good reference. Information on abbreviations, they have that there too. Black box warnings and FDA alerts, up to date on that if you want to catch on the latest stuff like that. They have a newsletter and email subscription. I don't know, again, something that interests you. It takes like 2 seconds to read their highlights on their newsletter, so it's not a big time commitment. NIOSH is another thing that is really important from a perspective of handling medications. And so NIOSH covers a bunch of things. So it's the National Institute for Occupational Safety and Health, but there's a hazardous medication subset of this. And you can Google NIOSH list or whatever. I don't think it's been updated from the government since like 2016, but they have hazardous tables. So they break things down by teratogenicity, carcinogenicity, and just general handling precautions. So like if your patient, maybe if you have a caregiver who is like a woman trying to get pregnant, for example, and she wants to know if she can handle her grandma's medications because she sets them all up for her. That'd be a great example of something that might come up on a random basis that you might not know where to find that information. And again, the NIOSH list is where you can find whether or not you should do that. And it also gives recommendations for how to handle those types of things too. So we want to make sure our healthcare professionals are protected. We have a lot of regulations around how we in the pharmacy prepare things, but when people are in the community, who knows what they're doing? So just to talk about some of the best practices out there, and certainly people could say, well, I'm not really worried about that particular side effect, and that's fine. For example, warfarin is teratogenic potentially, but how many people crush that and potentially get exposed to that? There's risks and benefits there. So it depends on the person, how comfortable they are, but at least giving them the information is, I think, important in some of those situations. IHI's Institute for Healthcare Improvement, they have a list of high alert medications. Again, I link back to ISMP here too. They're kind of one and the same as far as what they do. And they also talk about guides for harm prevention, which we'll talk about a little bit later, and how we work on some of that. Okay, so another thing that comes up all the time is patients asking where they can dispose of their medications. I mentioned this during one of the previous lectures, either talks or drugs of abuse, I can't remember. But anyway, this link is more up to date than what I've got in here. There's actually a lot more of these Dropbox locations now. And if you go to the link, I think there's, in the 30 to 50 of them around the cities now. Some of them are at pharmacies, but a lot of them are at police stations throughout Hennepin County. And there's other counties as well in Minnesota that have the same thing. The nice thing is they're completely free. There's no questions asked. You're supposed to bring the medications in the original package in your container, but if you dropped off like a bag of empty pills or a bag of random pills, I don't think anyone's going to notice that you did that. So if you really wanted to get rid of something that was all mixed together, you could, and that certainly happens from time to time. Just so you know, this isn't like a needles or sharps, so don't tell your patients to put their stuff in there. A lot of pharmacies take sharps containers back. That's usually the way that they can do that in the community, or clinics sometimes take them back as well. And businesses, healthcare facilities, so like if you have expired stuff from your clinic, if your clinic accepts samples or anything like that, that wouldn't be an acceptable use. You can usually go through distribution channels to get either credit for that medication or return that medication. So again, it's only for the consumer side of things. All right, adverse drug events. So what's the definition of an adverse drug event and why do we care? Well, we've talked about these a lot throughout the course, and there's reactions and events. I think of an adverse drug, an adverse effect produced by the use of medication in the recommended manner. So there's certainly preventable and non-preventable situations here. So like I think of a non-preventable adverse drug event is somebody with either like a minor side effect like dry mouth to something anticholinergic like an antidepressant, or if they get anaphylaxis to penicillin. Well, that's significant. It's not something we can predict in every person. So we don't know if you're going to have anaphylaxis, never had the drug before. Take it, then all of a sudden we know. So we can treat it, but that's just something we can't prevent. We want to focus on the preventable ones, so things we know cause we can monitor for, and then we can work towards better outcomes in those particular categories. So why do we care about this? Approximately 1.5 million preventable adverse drug events per year, so it's about $3 billion on the healthcare system. Half of all hospital-related errors and 20% of all ADEs attributed to poor communication and transitions of interfaces in healthcare. That's one big thing that we can make a difference on, so that's really everyone's responsibility. It's not just the providers, it's not just pharmacists, it's not just nurses, it's everybody kind of working together. Average hospitalized patient subject to at least one medication error per day. Now that's not means they don't get a medication error administered to them. That means they're potentially exposed to one. So when you look at all the different systems we have in place and all the fail-safes, that's what can possibly happen at any given point within the medication distribution process. Adverse drug events account for 2.5% of estimated emergency departments, and 6.7% of those lead to hospitalizations. And occurrence is unattended medication discrepancies at the time of hospital admission ranges from 30 to 70%. So that means that somebody comes into the hospital and their home med list is inaccurate, at least in some capacity. All right, so one of the most significant risks to hospitalized patients are adverse drug events. It can occur to up to 30% of hospitalized patients. In statistics will show 1 in 1,000 will get long-term disability, and 3 out of 1,000 will actually die from an adverse drug event. The burdens financially is significant. Usually these increase hospital length of stays. Every time you get an adverse drug event, estimated to be $1,900 to $5,900 per event, depending on the literature source. So big economic challenge here. So anything we do to move that needle a little bit towards safety is going to not only be better for our patients, but it's going to save money too. So how do we do this? Well, just to give you guys a feel for what happens, like if you work in the hospital setting and you put in medication, the order goes through a pharmacist. So I would review that and say, okay, my radar's not really going off. It looks like a standard medication. My computer's not telling me there's any significant drug interactions. I'm looking at your profile a little bit, patient profile, to see if the labs look good and everything like that. I go ahead and verify that. It goes down to pharmacy. Pharmacy will decide where to dispense that medication. It might be stocked on the floor. It might be something you need to send. But either way, anytime a medication leaves pharmacy, it's usually picked by a technician and checked by a pharmacist. Gets to the floor, the nurse would validate that. Usually they physically look at it, make sure it is the right thing. And then ultimately there's something called bedside barcoding where they can scan the patient and scan the drug. So all drugs we dispense at Abbott, with the exception of a few really odd items like specialty compounded stuff, have a barcode on it, whether it's from the manufacturer or one we assign to it using the product's code. We can make our own barcodes and put on stuff. But the idea is that at the bedside, everything's getting scanned before it gets to the patient. And you wouldn't believe it, like when we went live with this a few years ago, you'd get calls from nurses and they'd say, well, I'm scanning this thing and it keeps coming up as invalid. I'm like, well, what are you holding? Sure enough, it's not even the right drug. So it's like, again, sometimes people just get in the mindset that they might have pulled it. It might have been stocked wrong in one of our machines. So one of our technicians might have stocked, losartan and lisinopril or whatever it might be, or the wrong strength of something. So it's not necessarily the nurse's fault that they found the wrong wrong medication. But again, there's a lot of human flaws, so we try and put electronic systems in place to at least safeguard. And approximately 78% of adverse drug events are linked to either not scanning at the bedside or not using computer physician order entry, or computer provider order entry is probably more correct terminology. But if you think back to, well, I don't know if anybody here's worked in a hospital where they had paper charting. Anybody? Any chance? Okay. So messy, probably. Not lots of handwriting errors, lots of difficulties getting communication. Sometimes hospitals had multiple systems set up, so they had different computer systems for pharmacy, one for note entry and other things like that. Most hospitals, I think every hospital in the Twin Cities, with the exception of Children's, has not only CPOE, but they're all on Epic now. And Children's, I think, is looking at switching to Epic. They have Cerner, and Cerner is very similar to Epic. So places with CPOE, that's the cutting edge. Well, that's pretty standard nowadays. I've actually never worked in a hospital without it. So, and that includes the VA system, which has kind of their own homegrown one. Mayo just switched. They had their homegrown one too, and they just switched to Epic last year. It cost them about $2 billion. Not cheap, but definitely saves. Evidence shows time and time again that you save adverse drug events from occurring. There's other detection methods too. You can do chart review. You can look for things. It's really difficult though. The point in me putting this bullet on here is that there's not a really good system out there that will tell you if an adverse drug event is happening in real time. Some strategies are things like trigger tools. So a trigger tool would be like if your patient was on heparin and their platelets dropped for no reason, you'd maybe get a firing. Now that's still not in real time, right? Because you have to wait until the platelet level comes back, which means it happened in the past. So we never really know what's exactly going on in the person's body at that time, right? It's not really possible to do that with the current technology we have. So you have to always go back in time and look at their lab values and follow that trend. But we can do alerts and systems like that that say this is going to fire, like if your potassium, I don't know, I'm trying to think of a drug, but really jacks up potassium a lot, and that kind of blanking on the 6-methyl-choline, which would be kind of an odd situation, but let's say that happened, yeah. Anyway, you could have triggers for these really high-risk type situations, whether they might be blood dyscrasias or electrolyte abnormalities, and then possibly linking those to a specific medication as well. I'll just say really quickly, like this incident report system, this is really what we base a lot of our things on. So at our hospital, and then within Alina, we have something called a patient visitor safety report system. So if you experience an issue or some sort of event, you can fill these out, and anyone can fill them out, whether it's a patient, a visitor, or an employee. And so like I'll get things sent to me related to our distribution systems and the way we move drugs around the hospital that might relate to what I do on a day-to-day basis, that say, you know, this was taken out and it was expired or something like that, or a nurse found an expired medication. That's pretty benign. We can fix that. They caught it at the site. You know, don't really care too much. It happens. What happens if, you know, the nurse gave expired medication, or what happens if they gave the wrong medication to a patient with an allergy, or they overdosed somebody on Lasix or accidentally because the home medication reconciliation had them on twice the dose as what they were actually taking. So those are the things that get a little bit deeper, and so those are how we analyze some of our system failures and incorporate things that have fail-safes. But a lot of times we do rely on retrospective analysis and people like you guys and me reporting these events when they happen. If something bad happens and you don't report it, don't assume somebody else will. You could ask somebody. I've had providers ask me to write up PBSRs before, and I usually do it. So certainly if you don't have time, you could ask maybe a nurse or somebody who is more involved with it to write it up. But it's definitely important that those get reported. Most health systems utilize a process similar to that. Know your EMR well and err on the side of safety. Those sound like kind of common sense things, but you'd be surprised at the things people might put through, and it's just like, did you question that or think about that, or like the duplication of things that sometimes gets through. Like I'll verify an order set for somebody, and then somebody else will come in, and like the PA, or not the reg on PAs, PA or MD will put in an order set, and then the nurse will come in and put in the exact same order set and verbal order it under that provider's name. It's like, did you guys not talk, or what exactly happened? It's not a big deal because I can just discontinue one, but if the two get ordered and then somebody happens to administer double medications, that gets the problem, because you can chart on two different entries then. So know your EMR, use your tools, know how to quickly get your labs, drug interactions, identify allergies. One of the things I get from providers a lot is questions about allergies. So the question commonly is like, oh, this is flagging as a penicillin allergy. That means I can't get them amoxicillin. So do you have a recommendation for a different antibiotic? I'm like, well, let's step back a second. What's the actual reaction? Was it nausea and vomiting? Was it upset stomach? Was it they got itchy? Was it unknown? Or was it actually an anaphylactic type reaction? So that's what we obviously care more about. So if they just felt nauseous on it, like sometimes, like somebody got nauseous when they're on Augmentin, so somebody will be like, oh, they can't take Zosyn now. It's like, no, Zosyn's IV and it's probably not going to cause a lot of nausea. So I don't know. Just use some common sense with that. And I think the problem is it flags it as an allergy no matter what. And so you might see that big yellow flag and just say, well, that's an allergy. I should be careful. And that's good to see that alert. But also you need to dive into that a little bit deeper and say what exactly was causing that. And don't make extra work for people. This is as somebody who gets, a lot of random stuff that they clean up. I think most people are pretty diligent, to be honest. But again, the duplication of order sets and being clear in your instructions, like don't leave something up to chance. So if you discuss something with the nurse, don't assume that they're going to enter that order for you, or if you discuss something with the pharmacist, don't assume they're just going to enter it for you. Finish the conversation, say, okay, are you good putting that in for me, or do you want me to put it in? Generally speaking, you should always put in your own orders. Verbal orders are where mistakes happen, and so best practice is not to pawn off verbal orders on people. And certainly in situations it makes sense to do that, like if you're in a code or if you're doing something a little bit more, hands-on, like in a procedure or something like that. But it's definitely appropriate in the majority of situations for you guys to enter your own orders as providers. That's, again, the whole system here. If I enter the order and verify it myself, I just took away one safeguard in checking that because I checked myself on that, which I can do legally, but it's still not something that's preferred in most situations. Same thing on the outpatient side of things, like for your prescriptions when you're writing them. Make sure that if you're e-prescribing, you know what's going into that. Again, if you're having a nurse do that for you, see if you can have some sort of system in place where you can co-sign and double check that as you're co-signing, which is a function in most electronic medical records. All right, so again, a little bit of segue there. E-prescribe if you can. Handwriting and errors, obviously have issues with them. Pretty much everyone e-prescribes, or at least they print the prescriptions. For some reason, like some practices don't do e-prescribing for whatever reason. And that could be like our ER doesn't do e-prescribing. We just print and give it to the patient because it gets too complicated where you're sending it. And you oftentimes want to make sure that they get the antibiotic or whatever you're giving them in hand before they leave. There's some studies out there that say if you give a patient a prescription, there's a 70% chance they'll actually fill it. If you give them an actual medication, there's a much higher chance they'll actually start taking it. In fact, it's closer to 95% chance they'll actually take it. So that's one of the statistics that it's nice if you have a pharmacy on hand, like if you work in an ER. If you work at a freestanding ER or a freestanding urgent care clinic, you might not have that luxury. So just knowing where they prescribe, where they fill their medications is probably important. But again, e-prescribing and having it filled for them, it adds convenience for the patient. And so if you don't do that, it might end up with them forgetting to fill the prescription, losing the prescription, whatever it might be. Okay, if you don't have access to an EMR, you might have to do more checking. So the nice thing about medical records, assuming the patient's in your system or a system that's connected to it, you can look up all their medications, allergies, notes. So anything with Epic has access to anything else with Epic within reason. So like if somebody comes to Alina and they mostly do their care with Fairview, I can look at Fairview's most recent notes, their medications, and a lot of that stuff actually integrates now. So you don't even really have to go to separate screens, which you used to have to do it all separately, and now the chart notes will kind of pull in and make it a lot more seamless, which is really nice. So that's a great aspect, but if you don't have that, just old-fashioned talk to the patient. I know, again, this sounds kind of self-explanatory, maybe even a little bit dumb, but ask your patient about their medications and allergies. Don't assume that the pharmacy you send their prescription to will do a full, thorough counseling job either. Legally, by law, pharmacists have to counsel on new prescriptions, but if there's really specific side effects or really specific details you want them to get, that's on you ultimately. So make sure that if they hear it twice, great. It's probably better for them in the long run. Cost will come into play occasionally. Pharmacy will call you if it's not covered by insurance. I've talked about cost a lot here and there. You can always call place in advance too. Like especially Our psychiatry unit does that a lot because a lot of times we start newer antipsychotics on people that might not have been used in the past on that particular person, and insurance coverage is always a question. So you can call the pharmacy and ask to do like a test claim. They'll get the insurance information, they can run it and tell you how much out of pocket it'll be. That way you can have a good idea for what the cost will be to the patient before you even prescribe it to them, versus sending them to a pharmacy with the medication's got a $200 copay on it, and then they call you back and like, well, what am I supposed to do? I can't afford that. So a little bit of homework on your end, and usually pharmacies, again, are pretty willing to do this. They might require a little bit of legwork on them. They might not be able to do it in the exact second you need it, but give them some time and they should be able to get back to you with that. All right. Moving on to transitions of care. All right, so what did I say about transitions earlier? Basically, if somebody moves any point within the healthcare system, that's a transition of care. So I think of the most common things would be going from outpatient to inpatient and vice versa. Hospital to assisted living and assisted living to home are another big area where a lot of stuff gets missed. One of the biggest reasons for that is most assisted living groups, while they have access to like electronic medical records, it's usually not Epic. They're usually using some other brand. And so the seamless transition isn't there. And most health systems don't own like long-term care facilities or transitional care facilities. So again, there's a disjointedness between the computer systems, and every time that happens, the likelihood of something getting missed goes up significantly. So again, this is the easiest place to make errors. Like I showed you the statistic, 30 to 70%, and I would say I do a lot of admission interviews for patients to get their home med lists up to date. It's a big thing of why we use pharmacists in the hospital for a certain aspect of our job. It's something we've taken over. When I started as a resident at Abbott, we were doing like 30% of admissions, and now we're doing close to 98% of them. So every admission into Abbott gets touched by a pharmacist or interviewed by a pharmacist at some point, or at least reviewed electronically by a pharmacist. So that's something that they've invested in as far as a health system by hiring up pharmacist staff, because they believe, they being like the corporate Alina, believes that's really important. So if that says something, and we don't bill for that service, right? That's nothing, we don't have a tangible benefit we're giving from that. You could say, infer that by doing that we're saving med errors and stuff like that. That's really hard to measure. If you aren't causing med errors, you don't really know how many you're having. So again, why are these really important? And so from my perspective as somebody who does this a lot, it's just so, I can't even think of one that I've had that's come into the hospital. I'm like, yep, that's a pretty perfect med list. Occasionally it does happen where it's almost all right, but almost all the time I'm adding something, I'm deleting something. More often than not, I'm deleting old stuff that's on there, like an old prescription that was, from a surgery left over from 2 years ago that just never got off the person's med list. Or they stopped taking a medication because it was ineffective, and the prescriber told them to stop and started them on something new, but they never removed it from the med list. So again, that stuff gets lost in translation between clinic and hospital a lot. And also when people leave the hospital, they might not get that same communication where somebody's telling them to stop a certain med or restart a certain medication. So what do? We do something called MedRec, which is actually more like the more technical term or correct term for it is medication history. Medication reconciliation is when you as a provider reconcile their home list with their inpatient orders, or vice versa, reconcile what they're getting on the inpatient side with what they're now going to get on the outpatient side. So that's ordering medications. That's kind of the final step in the process. What I try and do before that as a pharmacist is get that list as current as possible, so that when you are actually ordering the medications, you have the accurate information to work with. Does that always happen? No. Sometimes the orders get put in and then the pharmacist has to go back and do things. Then you get a long note saying the following things need to be corrected because they were wrong from the home med list. And a lot of times that happens. I'm trying to think of some common areas, but like, for example, surgical clinics that send in like fax over an H&P that's completely wrong. I feel like those things are never right. I don't know why it's so hard for surgery clinics to get home med lists right. It's really kind of appalling almost, because it's like, didn't you take time to sit down with the patient? Like, they're literally telling me right now that they don't take this, yet it's on your H&P. Like, who the person's with it, they're talking to me. It's not like they didn't know that. So sometimes I just wonder like what goes on in some of these different areas where there's no good communication, or who's doing it. Maybe they aren't really trained to do it, or they just went through it really fast and said, are you still taking all these medications on here? Can you look at it? The patient kind of glanced at it and said, yeah. No one took the time to actually go through it in detail with the person. And that's what kind of is the problem with this, because it does take time to go through all this. It does take time to sit down with the patient and talk to them about their medications. You know, I can go through the EMR and kind of look at secondary sources. We have a lot of cool things that show us what patients have been filling on the outpatient. So for example, like I can pull in and see what you filled in the last year at most outpatient pharmacies based on your insurance records we have on file, which is a pretty cool, powerful tool. So like if I don't have, let's say, your metoprolol on file, but I see that you filled it last week, I'll say, do you take this still? Oh yeah, I don't know why that's not on there, and then I'll add it on manually. So there's some nice secondary sources we can do to help people jog their memory and check people that way. But at the end of the day, it's kind of a manual process, which is why it's fallen to the side over the last several years and kind of come back into the forefront of why it's important to do. So anyway, that's the big component of medication reconciliation. Discharge counseling is really important, again, to go over those changes with the patient and make sure they're fully aware of what changed inpatient, what they're starting, what they stopped. Assessing their medication needs. So do they understand their regimen? Do they have access to refill their prescriptions? Do they need refills? So maybe even something as simple as, you know, they came in on a medication that you aren't changing, but they don't have any refills for it, or they've been out of it for a month. So that's something you might need to address as well. Affordability of medications too. So can they, you know, like I go back to my very first lecture, I think a medication isn't effective if the patient can't afford it, right? So you have to be able to make sure that they can obtain their medications, or, you know, what you're prescribing means nothing. Provide patient with the medication. So again, I talked about this already. The solution, if you have a pharmacy on site that you can get them their medication, that's going to take away that issue usually. All right, so I started talking about this already, but just, again, talking about the process. So people will verify a medication list. Again, that's what pharmacists do. Nurses do this a lot, too, depending on the institution. They might not have pharmacists do this all the time. But if pharmacists don't do this, it is usually part of a nursing admission. So if you come into the hospital, your nurse should be reconciling this as your pharmacy department didn't. Clarification, ensure that everything's appropriate, and then reconciliation is, again, ordering them. And then, again, I kind of broke down who has what, but I already talked about that. I'll just show you an average of what we did, and just to drive home the point of how important I think this is. So at Abbott, we did 2,300 medication reconciliations were documented over a 4-month pilot period. So an average of 3 differences in the home med list per patient. So you know, if you break that down per patient, we're finding about 100% or close to 100% of people needed some sort of an adjustment on their med list. Average time about 23 minutes per admission. So again, that's a big time sink. When you already have a bunch of patients to see, can you imagine adding 23 minutes just to talk about medications? So that's why a lot of this got outsourced to pharmacy. Adverse drug event prevention chart analysis of 138 patients showed 17 adverse drug events prevented. So there's that cost there, whatever. That's, again, kind of funny money. We don't really know for sure. Patient satisfaction. Everybody was pretty happy for the most part. Some people weren't, but statistically we did well. And then physician satisfaction. We did this pilot with our internal medicine physician group only. They don't use APPs for whatever reason. So most of them were pretty satisfied on us. And basically they were the ones that pushed for this. We started doing it for them through various capacities, like our emergency department pharmacists would start to do medication rec before patients would leave the ER, and the hospitalist admitting group that would follow them would just basically rave about this, and they started asking us to do it more, but we didn't have time. So finally we upped our staff because we had so much pressure from that side of things. Then we did some data analysis to say, like, are we really having an impact here? So again, important time savings for not only the provider groups who are using it, but also ultimately for the pharmacists. So if I'm a pharmacist in the ER, and I verify your medication list and it's all good to go, you get admitted, you guys as the provider order the medications, they're all right. For another pharmacist on the floor is going to check all those medications before they clear them. They know that they've been reviewed as well. So it saves everyone a lot of work down the road. Whereas if somebody comes in and their med list's wrong, and you guys order it, and then that pharmacist is going through it and saying, well, this doesn't look like it's been updated for 4 years, they start digging into more and find out there's dosage changes and medications that are on there that aren't being taken anymore. We had an example of, we've had a couple examples. I think I gave you the furosemide one earlier. I wasn't making that up. That actually happened, where somebody was in clinic and they their furosemide dose was decreased by half. They ended up getting admitted and it doubled. and they went into acute kidney injury and ended up in the ICU because of a MedRec error. Because that medication got ordered before medication reconciliation was done, and no one QA'd the dose because the pharmacist didn't have time to get to it, and we weren't really doing that type of work at the time. So those are the types of things we're trying to stop. Other good one was somebody who was on Effexor at home, or venlafaxine, and they came in to our hospital. It wasn't restarted because it wasn't on their home list. A pharmacist found it reviewing their some other sources a few days later, and they were actually acutely delirious and agitated, and they were in the hospital, ended up in the ICU for a couple of days as well. Finally, they got their Effexor restarted and could proceed with their other reason why they were in the hospital to begin with. So those are some examples of things. Again, if you get missed, a lot of this stuff doesn't have a huge impact, fortunately, but there are certain things that can have a really big impact and can actually negatively affect patient care significantly. So just to give you guys a couple of real examples there. All right, so whose job is it to make sure this stuff all works? And I'm not just talking about inpatient, but outpatient as well. It's everyone. So it's everyone when you touch a point of care, when you interview a patient. If you change a medication, if you add a medication, if you're counseling somebody on a new medication you're thinking about starting, it's always important, regardless of your profession, to make sure you're updating the EMR or updating the patient's list. Some institutions have specific protocols. I talked about that a little bit, whether it's a nurse or a pharmacist. Sometimes too many people get involved, like a nurse might play with it a little bit, a pharmacist might play with it a little bit. I think the nice thing about us having pharmacists do most of it is our nurses have mostly kind of gotten hands off, which is good and bad, because if we miss somebody, they just wait for us to do it instead of trying to do it themselves. The nice thing is, if you have too many people altering it and don't know what they're doing, you end up with odd things on the med list that don't make any sense. You have lots of different ways to get a hold of people, whether it's calling their home pharmacy, using your electronic medical record, using other health systems information, reading clinic notes and discharge summaries. Again, I can't tell you how many times I've seen changes in an Allina clinic that were documented in a clinic note that weren't updated and reflective of the actual home med list, which, again, that kind of blows my mind as to how that wouldn't be part of the process, but it does happen. And I don't know what somebody expects them to do, like if their patient comes into the hospital unconscious or for a surgery or something like that, and that doesn't get updated. They assume I go to Allina hospital, I go to Allina clinic, I'm in an Allina hospital. How would that not be updated? And it happens all the time. Previous facility lists, people who come from nursing homes usually have a very detailed document on what they're taking, or a transitional care facility or something like that. Or if they come to you in clinic and they were just discharged from a nursing home, ask to see their nursing home MAR. MAR is a medication administration record. That's going to have exactly what they got, when they got it, because their med list in your system may be inaccurate. What if they're in a nursing home for 2 months, and let's say they were in a Allina hospital, went to a nursing home, now they're in your Allina clinic, and there's a 2-month gap there that is the discharge summary and what they're on taking when they left the hospital, and now they're in your office with that same med list, but then there's the nursing home 2 months information of what they actually got. And usually things get streamlined or changed during nursing home visits, so certainly make sure you're taking that into consideration, not just assuming that they were on exactly what they were taking when they left the hospital. The PMP is a prescription monitoring program. I talked about this a little bit during the opioid lecture, but that's a good tool. It has all controlled substances in there. So if you're like, gosh, I kind of know what this person's taking, but I really don't believe that they've been filling tramadol regularly or whatever it might be, you can pull that up via the PMP. I do think that one caveat, and I'm probably preaching to myself here a little bit more than anything, but this is a really important patient care aspect. I think a lot of people view medication histories and doing this as just clerical, annoying work that's labor intensive and not very fruitful, but I think it does have a pretty big impact on the patient's stay ultimately. All right, so some general other tips. If you're in the clinic, your patient should have a current detailed medication list so they can keep with them and update as needed. Whether the patient has it on their phone or paper copy or whatever it is, make sure that they know what's changing and what's being updated. You can certainly print stuff out or have your nurse print out an update if you've updated it and reviewed it and think it looks good. You could ask them to do that for you when they discharge the patient from the clinic visit or whatever it might be. But those updates can really help. Patients should get a new one. It's always a little nerve-wracking when I get something. I just was in our OR doing pre-op visits the other day, and I had somebody give me a sheet, and she was kind of short with me, and she's like, this is everything on there. He took all that stuff this morning, and there are a bunch of dose changes documented in the margins in pencil and all this weird stuff. And it's like, okay, I have to go back in there and actually sit down with her for about 20 minutes and talk to her about all of it. And she's like, well, I didn't know that wasn't in there. And it's like, yeah, I didn't say, I wasn't mean to her, of course, but it's like, how was I supposed to interpret all these changes and what's actually accurate? So giving them a new list occasionally is probably not a bad idea. If they're in the hospital, again, the big part that you're going to be doing is actually reordering the medication. So you really want to be 100% confident and have 100% confidence in their accuracy. So did the MedRec get done? Was it actually completed? Did pharmacy review it? Did nursing review it? Did somebody look at it? Is something not look quite right? Like maybe you thought you talked to the patient before they went into surgery. Now you're interviewing them in the hospital, and you're like, I could have sworn this patient was on insulin, and there's no insulin orders. What's going on with that? Is pharmacy available for consultation if needed? So ultimately, do you have access to a resource like a pharmacist who can do who can provide that medication expertise if you want them to do a more thorough review? Or do you know how to do some of that yourself? And can you look at some of those other sources and figure that out? So again, just to review, summarize this a little bit. List acquisition, you're going to look at profile review, interview your patient, look at secondary sources, know how to use your EMR and do this accurately, know when to remove medications or alter medications. I think this one's actually, it doesn't seem that important, but it is. A lot of people will see this as, especially I feel like this is a big nursing pitfall, so just maybe more for your information, is that nurses, both in the clinic and on the clinic side and the hospital side, they seem to be really hesitant to change anything or delete anything. So a patient might tell them, yeah, I don't take that anymore, and they'll put in a little sub note underneath it that says, patient says no longer take it. It's like, well, why don't you just delete it off the medication list altogether? Because I might not see that, and you might not see that they put in that note. So again, I'm not trying to, I think nurses are just trying to be really cautious, and that's probably a good thing. But that's one of the biggest things I found, especially when nursing was doing a lot more MedRec at our hospitals, that they were leaving lots of stuff on the med list, and things would get reordered again that weren't actually accurate. So that's one thing that if you work in a facility that's heavily nursing run, they might be much more hesitant to actually DC a med. Whereas I'll just go through and do a clean sweep. Nothing makes me happier than to take a med list that's like 20 things of junk and like stream it down to 3 actual medications the patient's on. I get a lot of weirdly I get a lot of satisfaction out of that. I don't know why, but that's just me. So you can call me if you're at Abbott, and I'll do it. Yeah.
If somebody brings like a significant other, they bring their whole bag of meds with them. They don't continue to take their prescription meds out of their bottles.
No, that's a good point.
See what it is, and you would transfer it over to the hospital administration.
Correct. Yep. So this happens a lot where people are like, why did they, especially post-surgery, I think some of the clinics tell them to bring the meds with, some of them don't. I think it's ultimately so that they have that reference there and they can look at the bottles. We don't really need to do that in most cases. But if somebody does use it, bring it in, we can store it in the hospital. We don't use it, though. So we talked about the bedside barcoding. That would override that safety feature if they're taking it out of their bottle. Kind of a side point and a good thing to discuss that actually comes up quite a bit is patients come in and they want to use their home meds. They're like, well, I already paid for these. I don't want to pay for the ones you're giving me in the hospital because you'll charge me $100 for an aspirin dose. That's a little bit of an exaggeration, but it's actually not really true. Most hospital visits are billed in a bulk charge. So like, let's say you're hospitalized for pneumonia and all those medications are included. So most insurance companies will pay a hospital, like, let's just throw out a number, $5,000. Say, okay, this was an uncomplicated pneumonia. They needed a few days of hospitalization. Here's $5,000. If you spent all that $5,000 and more than that, well, the extra money, that comes out of your bottom line. If you saved, if you spent $3,000, you get to keep $2,000 in profit. Good for you. So it's an incentivized thing like that. Most places don't individually bill for certain things. Now, some insurance plans are like that, like sometimes Part D, Medicare Part D plans, so for like retirees, if they're in an observation status, which happens a lot more now than it used to, they often won't pay for some of their medications, so they might have to pay out of pocket for some of those charges. So there are certain things like that that come up occasionally, but I'd say I think we had this discussion with our billing department a while ago, and they said basically for 95% of cases, medications are lumped into the charge. So if a patient takes their own med, they're actually costing themselves more money because they would already be paying for that via whatever copay they had for the hospital visit with what we gave them inpatient, and now they're just using their home supply for no reason where they could just keep taking that when they get home. For those other 5%, there's usually like some sort of financial programs that allow for the payment of those for most of them. That's what our billing department was informing us on. Certainly there will be the one-off patient occasionally. It's like, oh, I remember getting billed whatever for this, those couple meds they gave me when I was in the ER. And certainly, again, some insurance plans are structured differently and unusually, but for the most part, that's all included. So like we have a policy, we don't allow home meds in the hospital unless it's something we don't provide. So it's something really unusual. Like I think of really expensive things like Hep C drugs, MS drugs. Those are really expensive. We don't stock them routinely because the overhead's so high on them. And it's usually a set course. Like Hep C, you get enough for whatever course is planned for you. So if you're going to take it, you might as well keep taking your own because it makes sense to continue that. Another one that we don't supply is oral contraceptives. So those ones people usually bring from home. Yeah.
Random question, but since it's on the insurance thing,
yeah.
What is like Good RX, or like how do you use it?
Good RX, is that like the voucher program thing?
I think so, yeah.
Yeah.
I've seen it, or like.
So most manufacturers have assistance programs for people who qualify, and usually the qualification threshold is actually pretty generous. It's like, I can't remember what they are, but it's a certain multiplier over the poverty, like the federal poverty limit. So you can actually be kind of middle class and still qualify for a lot of them. And most manufacturers have one. They're all slightly different. And I think that website, if I'm thinking of the right one you're talking about, is just a compendium of all of them together. So it gives you access to everything kind of in one spot versus having to go to like Glasgow and Pfizer's website separately and figure that all out. It's more of a one-stop shop type thing. Yeah, they're coupons. And a lot of the time it's actually pretty good. Like, for example, when the new oral anticoagulants came out, a lot of insurances weren't paying for them. And so to get people to take them, they would have these. We actually have this person called a liaison who works at our outpatient pharmacy, and she would go meet with people who were scheduled to discharge on Xarelto or Eliquis, and she would talk to them about their insurance. She would run test claims to see if it was covered. If it wasn't, she'd set them up with an incentive program via one of those drug companies, and usually it ended up being like a $10 a month copay, and it was recurrent for a year. And there was no restriction on re-enrollment, so you could just re-enroll after a year if you needed to. So basically it's almost like getting it for free if you look at the cash price of it. So again, a lot of those programs are out there. That's a really good point. So if you have somebody who's struggling with cost, that's something to look into for sure. Now, the patient might be willing to do a lot of that on their own, especially if they're more, I'd say maybe more tech savvy, but certainly it's something you could look into too, or you could have a resource to do that. Or a lot of pharmacies are really familiar with this too. And basically the way they do it on the discharge pharmacy side or the retail pharmacy side is they bill it like a prescription, or like an insurance plan. So they get a special code to put in when they process it, and then it submits it to the drug company instead of an insurance company, and then they approve the claim or not. So again, sometimes that takes a little bit of work to set up, and that's what our liaison person was doing. So it's kind of, she still is there, but it's kind of a cool position she had because she would actually like her position would help get people discharged like days earlier instead of having somebody sit in the hospital because their insurance was on hold because they can't afford a $300 a month medication. She could get it all done ahead of time and put them on it at the day of intended discharge and then get them out of the hospital. So it's actually a really cool incentive. A lot of, like Fairview does the same thing. A lot of hospitals do this type of a thing. In fact, we stole that idea from Fairview. So give them credit where credit's due. But there's a lot of things like that out there where you can get incentives for that. And again, don't think about it like, well, this person's not, a Medicaid patient. They won't be able to qualify. That's not what it is. In fact, Medicaid patients usually do qualify for that stuff. So anyway, the point is that you don't have to be like at the poverty level to get incentives from drug companies. A lot of people who make normal incomes will be able to qualify for that type of stuff. All right, some other just things to talk about. Questionable historians. This is always interesting. How do you trust a person? I can't tell you how many times somebody's come up and told me I read your note and they told you different things than they told me. I'm like, yeah, I don't know what to tell you. That's what they told me. They're like, they told you they were taking that? I'm like, yeah, she was pretty adamant about it actually. Wow, I didn't mention it to me at all. Yeah, so it happens occasionally. Some of it just might be the way I ask questions versus a provider, and nothing that there's a right way or wrong way to do it, but I think I approach things, obviously I'm focused on the medications. I'm not thinking about anything else while I'm in there, so I might be able to pry out information. I also think patients might be more open to talking to a pharmacist, believe it or not, than maybe a physician, depending on their past experiences, or you think the pharmacists are the most trusted profession in the world. world or whatever it is, which probably isn't true. But I think a lot of patients do have maybe some sort of, maybe they get that white coat syndrome. So if I come in my maroon scrubs and I'm just some random guy talking about medications, they might not necessarily feel as much pressure. They might be willing to open up more about being non-compliant or non-adherent with me. They might be a physician who they're maybe afraid of judgment. Not to say you guys are judgmental, but you know what I mean, that sometimes people might think that, oh, this person's trying to take care of me and I don't want to let them down. Or maybe you're their outpatient provider and you're seeing them in the hospital and now they're like, oh yeah, I want to admit to not taking my Plavix. Yeah, I took it. So anyway, there's all types of things that can happen that way. Now, that's one thing, is if the patient's manipulating you or giving you false information intentionally. That's hard to tease out, right? If somebody's lying to you, well, what do you do? If somebody's unconscious or if they're agitated or whatever it might be, that's where you can rely on heavily on secondary sources. So, for example, like a lot of mental health admissions, if somebody comes in with acute schizophrenia exacerbation, I'm not going to go talk to the person while they're throwing their lunch tray at the nurse. That doesn't make any sense. So I'm going to look at my secondary sources. I'm going to try and talk to family. I'm going to try and see what information I can glean from the chart. When were they last hospitalized, if ever? What information do I have, and were they adherent with their medications? A lot of times sometimes people come in and they just have been off their meds forever. And in that case, it's sort of like a refresh. But it's still nice to know maybe what they took at some point. Clinical judgment. I think most patients out there, especially like, I would say if you can get to them before they get like doped up for surgery, they're really good. Like when I do the pre-surgical med recs, I'm getting to them before anesthesia gets to them. They're coherent. Most of them know what they're taking. Every once in a while they don't, but they usually have a family member there to guide them through it who has a list. They're very prepared, at least from what I find out. If I wait until that person's been like hammered with fentanyl for hours and now they're up on the floor, and they're totally out of it and they don't have their family with them, they're recovering from anesthesia, it's going to take a few more hours to really get them back. I might be looking at the next morning before I can get an accurate picture of what they're taking. And what if you have to order evening meds for that person and then you don't have that clinical picture? So that's why at our hospital we've tried really hard, even though we have a big surgery schedule every day, to talk to every person in surgery before they go onto the floor so that we get that accurate picture. And then again, if you're like working surgery, you're going to order the home meds when the person's done. A lot of our PAs fill that role at Abbott. I don't know what your guys' career goals are, but certainly that's an option to kind of manage the hospital care of the patient afterwards. And in that case, that's a really important thing that you know that's done. And I would think for you guys, that'd be a huge benefit that you know that somebody's actually taken the time to go through that with a fine-tooth comb and tease out all those information. I'm not saying we're perfect. No one is. But I think that we do, again, approach it with a little bit different angle than nursing or medicine would, because that's, again, why we're doing it. We're looking at that specifically. We don't care about anything else. That's why we're doing it. Verify all the components. So dose directions are important too. Sometimes what I think a big pitfall is when people interview patients is they ask them, are you still taking your metoprolol? Yes. Okay, move on. What dose of metoprolol? Are you taking tartrate or succinate? Do you know if you're taking long-acting? Do you split your tablets? All those types of questions are really important to tease out of the patient, because if you don't clarify that, what if there was a dose change and you just missed it? Now again, like the Lasix example, are you taking Lasix? Yes, I am. And you don't follow up with, is the dose still the same? At least that bare minimum question. So those things are oftentimes indicators for what the patient's doing. PRN products. So don't just skim over things that are on their med list as needed. Like I found something today on a new psych admit that the patient was taking they had an albuterol inhaler, and I saw that they were requesting a new one from pharmacy, and they just gotten one dispensed like 3 days ago. I'm like, what's going on here? But they're getting round-the-clock QID usage, and it was a PRN order. And so like they weren't on any type of a controller medication. So obviously that's not necessarily an admission med rec fault because she wasn't on anything at home, but catching those types of things. And on admission, if you were to ask, well, how often do you take that albuterol inhaler? Oh, I do it 4 times a day. Like, well, why are you doing that? Why didn't you have something long acting? Can you not afford it? Have you tried anything long acting? Should open up that conversation too. So anyway, not optimal management of that person's asthma specifically. So those are things that are like narcotics. What if somebody's taking oxycodone, or they have oxycodone on their list and they use it once a week? Well, who really cares? What if they take it 5 times a day? That's different, right? So they're not opioid naive at that point. It's going to change your whole treatment strategy for pain. Okay, discharge. Again, a lot of places nursing do this, but I think that providers, especially hitting the high points, is really important with the patient to remind them, okay, remember we changed you from verapamil to diltiazem or whatever it might be, to make sure that you are explaining that, why you did the change, what that's going to be like. If they have anything at home, to make sure they go through it. Talking to family members if somebody else manages the medications. I think that's sometimes a mistake too. It's like we explain to the patient, we don't explain to the daughter that's actually going to be throwing out the old meds and filling the pill boxes and things like that. Set up follow-up. So follow-up with yourself, partner, clinic. Somebody needs to follow up. The old mantra that some professor always said, it sounds super corny, but if you don't follow up, you don't care. So care about your patient and follow up with them, or make sure there's a follow-up plan in place. Because if they get 30 days supply of a medication, what happens when that 30 days is over? Do they have somewhere to refill that? Did you give them refills? Do you think that's appropriate for you to give them refills or somebody else to? Did you communicate that with their outpatient provider? Do they have access to all your changes and notes and everything like that? Or vice versa if you're going on to the inpatient side. To communicate with that inpatient provider and make sure that they are aware of any recent changes in clinic that might not be reflected in the EMR. All right, patient readmits because they didn't take their medications correctly. Super common readmission cause, believe it or not, and it's very, very preventable. A little bit of education goes a long way with readmissions. Now, some patient populations it's really tricky. So, like I would say, psych patients, for example, can get lost to follow-up. Heart failure patients, for whatever reason, are a really high readmission category for Abbott. Granted, we see a lot of them, but they seem to have adherence issues. So, how can we work with them to make sure that they're getting the follow-up care they need? So those are strategies you need to think about, because you don't want your patient coming back in. I think I've talked about this before, but from a payment perspective, obviously there's lots of problems coming back into the hospital for the patient, right? You're exposing them to nosocomial things. They're sicker if they need hospitalization. But a lot of times if you get a bounce back readmission within a certain amount of time, insurance will void the original payment for that visit. So they'll say, yep, you're taking care of that patient for free now. You didn't treat that community-acquired pneumonia correctly the first time. They're back in 30 days. All right, this new one's on you, so you can eat that whole cost. So it's a big burden on the financial system, and insurances are set up that way to incentivize you to do it right the first time. And a lot of that has to do with taking medications for some diseases. So making sure people are set up for follow-up and set up for success from that perspective. All right, so that's it. Again, nothing much to test on from this lecture with the exception of the short answer question around transitions of care. I did post a review set of cases and questions with a recording on there, so I won't spend any more of your time today going through that. It's just, again, multiple choice questions like you'll see in the exam. So that's there. Does anybody have any questions about the content for this exam that I could go over or review briefly? And the majority is tox and EM and critical care, and then those few questions from supplements and drug reviews will be pretty straightforward. Yeah.
In the drugs of abuse lecture, you said you're going to try to point us in the direction of where it was, and I guess I didn't get that direction.
Okay.
So that might have been me, but am I correct in just like focusing on the mechanism of action, withdrawal,
yeah, basically
treatments?
Yep.
Like, is that kind of what you're looking
That's
for?
exactly what I'm looking for. Yeah, think about kind of like an extension of toxicology. So focusing on the core drugs, like how they work, what type of class it's in, because that's going to guide your treatment, right? If it's a stimulant or if it's an opioid or something like that. And all opioids are treated the same way. So heroin's treated like oxycodone, like morphine, whatever. So yeah, from that perspective, that's really all I want you to know. I don't really care about the odd synthetics or anything like that. I'm not going to ask you weird questions about them. So I'm pretty much just focusing on the core ones. Again, mechanism of action. If there are any treatments, like for long-term, there weren't really many that I talked about, but or acute treatments as well. So like obviously naloxone for opioids, things like that. All right. Well, okay, my final thoughts. Thank you so much. Every year I learn a lot more, and every year, believe it or not, I do make lots of changes to the class. So I know my PowerPoint said 2014. I did update it this morning. So sometimes I forget to update the date. That's why I deleted them all. But the point is that I really like doing this. I like learning, and I like teaching it because I feel like I relearn it every time I do it. It's great to have you guys, and it's great to hear from you guys after you go on rotation. presentations. I don't get a ton of stuff coming back to me, but feedback is great, whether it's general through like Wally or Lisa for certification exam preparation, or more specific things like, oh, I was on rotation and they were talking about this. Do you have any things like that, or any feedback on why they use this particular treatment? Or every once in a while I get somebody saying, oh, you should pick this person as a guest lecturer or whatever, some things like that. I'm open to that, but those things just have never really panned out for me. But not a closed door there. So yeah, my email's not going to change, so feel free to use it. And if you have anything you want to run by me or any questions or comments or anything like that, I do a little antibiotic review in the fall for students who are on rotation. So it's just really quick. I just kind of do a scatter shot of random diseases and some of the core therapies, and then it's mostly a Q&A session. And it's not just antibiotics. I can't remember what we ended up talking about last time, like CBD oil or something like that came up. So anyway, it could be it could be all over the place. So certainly feel free to keep things in the back of your mind. You'll get to see me again for an hour, and you can grill me on a variety of things if you feel so inclined to do so. All right. Well, good luck. Thanks again.